as America's #1 cancer hospital. She is not only a surgeon of the highest caliber, but what truly sets her apart is her humility, like some of you here sitting in the front row have, approachability, and a distinct sense of responsibility. She leads with quiet strength and grace, earning her not just respect, but deep admiration from her colleagues, senior colleagues, junior colleagues, and fellows. And what struck me when I was interacting with several junior colleagues there, because they are the ones who can tell really about the senior professor, is that she's always available. Whenever there is a challenging situation, challenging problem, wherever in the world she may be, she's just a phone call away. And that speaks a lot about her kind and compassionate attitude. I can tell you for a fact that when I was at the MD Anderson, when I was due to visit, she had commitments at 2 major national conferences back to back, but she created the time, flew back to Houston just to spend a couple of days during my visit. And that gesture speaks a lot about you, Kelly. And you're not just a brilliant surgeon and an academician, but a deeply thoughtful human being. So Kelly, you're an exceptional clinician, a tall leader in every sense, and an inspiration to many. So we at the KIMS family feel really privileged and proud to warmly welcome you this morning. Please give a big round of applause. She'll be speaking on a topic, she'll make it as general as possible, Houston to Hyderabad, advancing surgery through collaboration and science. Professor Kelly Hunt.
Thank you so much. What an amazing pleasure it is for me to be here with all of you today. I've really enjoyed, I just came yesterday, but I feel like I've seen so much of your beautiful city already and gotten to enjoy some of the sights, and looking forward to more, and also the amazing food here. So it's really wonderful. So thank you again for inviting me here. It's a real pleasure to share some of the experiences that I've had as a surgical oncologist at MD Anderson. So these are my conflicts of interest. I do work with different companies developing drugs for breast cancer, developing devices, and I've served on medical advisory boards, but I'm not going to be discussing any of those relationships today. So I'd like to show this figure because it gives a little bit of an overview of the timeline of breast cancer treatment, starting from back in the 1800s, when really the only treatment that was effective was radical mastectomy, and even that was not very effective. Many women still died of breast cancer despite having very aggressive surgery. And throughout the years, we've learned a lot more about the biology of breast cancer and how we can modify our surgical approaches in order to have less aggressive surgeries but still extend survival for our patients. And part of that reason is because of the understanding of the different subtypes of breast cancer. So in this diagram is the initial description in the 2000s of gene expression profiling of different breast cancers and how they segregated into different types. And that was very important in terms of being a determinant of survival, but also in determining which type of treatments a patient might need. And along the bottom curve here is how all of the adjuvant therapies have developed over the years to treat different types of breast cancer. And indeed, we've just recently seen an explosion of even more targeted therapies and very important ways of treating breast cancer and extending survival and even curing patients with breast cancer. So what I want to focus on is more on the surgical management, and this includes not only the primary tumor that we identify in the breast, but also the management of the regional lymph nodes. So breast surgeons and surgical oncologists always spend a lot of time talking about lymph nodes and how many we should remove. And one of the things that's really changed our approach to both the primary tumor and the lymph nodes is the use of neoadjuvant treatments. So instead of doing surgery first and waiting to see after surgery which types of treatments we need based on pathology, we're now doing a lot more treatments before we do any surgery and then modifying our surgical approach based on what we find at the time of surgery. So the management of the primary tumor, as I mentioned, in the U.S., Professor Halstead at the Johns Hopkins University was really a proponent of the radical mastectomy. And the figure on the right shows a woman who underwent radical mastectomy. And what this meant was to remove the breast, all of the pectoral musculature, and all of the regional lymph nodes. And he felt that if you could do that, if you could remove that tumor, remove the lymph nodes that were downstream from the tumor, that you would be able to cure patients with breast cancer. And as I said, we've modified that quite a bit now because we know that not everyone needs a mastectomy. We still do perform mastectomy. There are indications when there are very large tumors, especially if the tumor is much larger than the breast. If there's multicentric disease in the breast, although we recently completed a trial that showed that some patients, even with multicentric disease, can have breast conservation. When we do mammograms and we see extensive microcalcifications throughout the breast, signifying a lot of in situ carcinoma, premalignant changes, that's an indication for mastectomy. And sometimes we do mastectomy for early stage breast cancer if a patient cannot have radiation treatment, if they have other diseases that prevent them from having radiation. And finally, genetic mutations. We're understanding that there are underlying mutations in BRCA1, BRCA2, ATM, PALB2, and many other genes that are important in predisposing individuals to developing breast cancer in their lifetime. So now, even before we detect breast cancer, sometimes we are doing mastectomies to remove the breast tissue for risk reduction. And typically, when we see a patient with early stage breast cancer, we discuss their preference as to whether they want to have a mastectomy or breast conserving treatment. And we try to counsel them on that. One area that we still have not veered from is inflammatory breast cancer, which is a rare but very aggressive type of breast cancer. And in those individuals, they're not good candidates for skin or nipple-sparing mastectomy. We do a typical modified radical mastectomy for those individuals. So when I first started doing surgical oncology at MD Anderson, we were beginning to do skin-sparing mastectomies. And this was in conjunction with our plastic surgeons doing immediate breast reconstruction. So what the skin-sparing mastectomy implied is that you take the nipple and the areolar complex and all of the underlying breast tissue en bloc. And this allowed to save the skin envelope, the shape of the skin envelope, so that you could then do immediate breast reconstruction. And we did this with both autologous tissue and implant-based reconstruction, and still is used quite frequently in our practice. We have looked at how patients do with a conventional modified radical mastectomy, where we take most of the skin of the breast, versus a skin sparing, where we try to preserve the vast majority of the skin envelope. And when we look at our patients at MD Anderson, treated almost 2,000 patients comparing conventional versus skin-sparing mastectomy, we find that the local recurrence rates are quite similar, very low, and that the distant recurrence rates are also quite similar. So we don't find any significant difference if we select the patient properly, if we use our imaging and other tools, our physical exam, to determine which is the appropriate approach for that individual patient. What about nipple-sparing mastectomy? Well, over 10 years ago, many individuals started using nipple-sparing approaches for patients, especially those with genetic predisposition where we're not typically doing breast conservation. We're usually trying to remove all of the breast tissue to reduce their risk of developing breast cancer in their lifetime. But again, we have to select patients appropriately, those that don't have any significant ptosis, and non-smokers, because we're trying to preserve the very small vessels in the skin and the nipple. And if you're actively smoking, that can influence the viability of the skin of the breast. So we do counsel patients because when you're removing all of that breast tissue, it can impact sensation and function. And we're also now beginning to do many nerve-sparing techniques so that patients don't lose all of that sensation. And this just shows some examples of how we typically use an approach along the inframammary fold to hide the incision so that when the patient's doing self-examination and looking at the breast, she is not, doesn't have that stigma of seeing the scars from her breast surgery. Now, when we examine the breast in the pathology suite, we have to mark the area of the nipple and the areolar complex for our pathologists so that they know where to focus that detailed microscopic examination, because all of the nipples do converge, all the ducts do converge there at the nipple, and we try to go directly and take all of the ducts behind the nipple, but there can sometimes be in situ disease that can predispose individuals to developing cancer in the nipple later. But fortunately, many individuals have looked at their results with local regional recurrence using this approach, and what you can see here is that it's very rare to see a local regional recurrence after nipple-sparing mastectomy. Again, that's with very good selection of the appropriate patient, where the tumor is located if they do have breast cancer. And the distant metastasis rate is also extremely low. So we feel that this is an oncologically safe procedure in selected patients who are undergoing immediate breast reconstruction. And so what about breast conserving surgery? Well, this is something that we've started using more and more as we've introduced screening mammography into the U.S. We're starting to detect many early breast cancers that don't require a mastectomy. We can do partial mastectomy and radiation, and that has been shown in many randomized trials to be equivalent to a mastectomy in terms of long-term survival for early-stage breast cancers. We've also started to extend breast-conserving surgery to individuals that have more advanced cancers that are receiving neoadjuvant therapy, where we can see a significant reduction in the size of the tumor due to the neoadjuvant therapy. And also, we recently published that it's safe for some women who even have more than one tumor in the breast, multicentric disease, to undergo breast conservation if they have negative margins. And so this just shows a couple of examples. We're trying to not only remove the tumor with a margin around it, we're trying to preserve the shape of the breast and make sure that they have good symmetry with the opposite breast. So in the U.S., the National Cancer Institute funded several cooperative groups, including the National Surgical Adjuvant Breast Project, to do clinical trials in breast cancer patients. And they've really made some landmark studies completed with the thousands and thousands of women who've participated across the U.S. and some other countries as well. And one of the first trials, the B06 trial, looked at women who had smaller breast cancers, less than 4 centimeters in size, randomized them to undergo a complete mastectomy. And at the time, we were always removing all the lymph nodes at the time this study was accruing patients. Total mastectomy versus a lumpectomy, or partial mastectomy versus lumpectomy with radiation. And at the time, you know, patients with positive lymph nodes did receive systemic therapy, but it was melphalan and 5-FU, which now we typically would not use for women with breast cancer as more and more agents have been introduced. And so mastectomy was performed if there was a recurrence in the breast after lumpectomy or lumpectomy and radiation. But what you can see in these curves here is that when you look at disease-free survival, distant disease-free survival, or overall survival, none of those differed depending on the surgical approach. And so this was a very important trial, and there were several other trials completed around the world that had similar results. At my institution, we also have looked at our long-term results from 1987 to 2005, over 2,000 women who had segmental or partial mastectomy with whole breast radiation. And at 5 years, we saw 3% incidence of recurrence in the breast, and at 10 years, 6% incidence. But more recently now, with better selection, again, with attention to surgical margins, we see an even lower rate. So our goals with breast conservation for the appropriately selected patient are to maintain local regional control, limit complications that might delay their introduction of adjuvant therapy, so systemic therapy in the adjuvant setting, meaning after surgery, and to preserve the shape and size of the breast with optimal aesthetic results. And this is very dependent on the location of the tumor and the breast to tumor size ratio. And so what we know from many trials in the US is that about 30% of patients will experience a significant deformity or significant asymmetry. And so we have now, as many others have done around the world, started using oncoplastic procedures to reconstruct the breast at the same surgery that we're removing the tumor, to try to also obtain symmetry with the opposite breast, whether that's a mastopexy or a breast reduction procedure, because that offers the patient longer-term good results, better aesthetic results, better able to go on with their daily life, wear their regular clothing without concern. And one of the reasons that we've been able to do so much more breast conservation is, of course, by doing screening and trying to find cancers when they're earlier, but also by trying to pay attention to the margin of resection of normal tissue around the tumor. And so this is important work from the Society of Surgical Oncology and the American Society of Radiation Oncology, where they looked at all of the trials around the world for women with stage 1 and stage 2 invasive breast cancer that had breast conservation and whole breast radiation, and looked at the margin of resection of normal tissue. How much normal tissue do you need to take to make it a safe procedure? So what they found is that positive margins, so if there was tumor at that inked margin where the pathologist inks the specimen after we remove it, that was associated with a twofold risk of recurrence within the breast. But more widely clear margins than no ink at the tumor was not necessary to support a decreased or a low rate of ipsilateral breast recurrence. And so this was very important because now more women can be candidates for breast conservation because we're not trying to achieve 1 centimeter or greater margins. So we use now no ink on tumor as an adequate margin. And this has decreased the number of re-excision procedures, women undergoing re-excision to achieve negative margins after breast conserving surgery. And so this shows, it's a little hard to see the cancer there because of the dense breast tissue, but this shows how a biopsy clip is placed at the time of the image-guided biopsy to detect the breast cancer. And then now we're using localizing devices like magnetic seeds or other GPS devices to localize with a probe during surgery so that we can achieve a segmental resection optimally with the tumor in the center. Our pathologists then take the specimen and they use different colors of ink. They section that specimen and then we x-ray it again to identify areas within that segmental specimen to try to identify areas that might be close to the margin that might be need for re-excision. As I mentioned, the use of neoadjuvant therapy has made a major impact on our ability to do breast conservation. These are some, again, the NSABP has been a real leader in doing these neoadjuvant trials. And you can see we have the B18 trial, which basically looked at patients having surgery first and then receiving adjuvant anthracycline-based therapy after surgery, or doing that same therapy, anthracycline with Cytoxan, before surgery, and then looking at outcomes including survival. And they showed there was no difference whether the chemo was given before surgery or after surgery. They did find that the chemo could shrink the tumor and reduce the incidence of positive lymph nodes. The next trial was B27, which added a taxane onto the anthracycline-based therapy, and now many other B40, B41, which is neoadjuvant regimens, adding biologics, and so again, advancing the way that we treat patients. There are long-term follow-up studies now for B18, which was that first trial showing that you could do safely neoadjuvant therapy and not impact outcomes poorly for patients. So you can see the survival curves, disease-free survival curves, and also B27, which was the next trial. Again, no difference in survival outcomes, but it did show us that it could reduce the primary tumor size so we could do more lumpectomies for patients. It also decreases the incidence of positive lymph nodes. So when we do lymph node surgery after chemotherapy, there are fewer positive nodes. And then the other thing that's very important is that it's shown us that the pathologic response that we see after the therapy is correlated with long-term survival outcomes. And for patients that have a major response, they have really excellent survival outcomes. So this is data from one of the trials that I was involved in, the American College of Surgeons Oncology Group. We also call it ACOSOG. This is the Z1071 trial, where we looked at patients who had positive lymph nodes that were biopsy proven. We gave them therapy directed toward the subtype of breast cancer that they had, and then they underwent surgery. And so what you can see in the curves is that in the dark bars are the ones who had breast conservation, and the lighter bars are the ones who had mastectomy. So for triple-negative cancers and HER2-positive breast cancers, we were able to do more lumpectomies for these patients because the therapy was more effective. And it's the hormone receptor-positive tumors where we were able to do some breast conservation, but did end up needing to do more mastectomies. And then what we see in the curves over here is that the dotted lines at the top are the patients who had what we call pathologic complete response. So even though we had a biopsy before chemo that showed tumor in the lymph nodes and they had a tumor in the breast, when they had surgery, there was no tumor left in the breast or the lymph nodes. So that PCR translates into better survival outcomes versus those that have residual disease. And so that is now a big focus of systemic treatments, is that after the surgery, if we identify residual disease, then we're targeting that residual disease with newer, hopefully more effective therapies. So one of the things that we've done at MD Anderson is looking at these exceptional responders and trying to see if they really need surgery at all. And so my colleague Henry Cure is the PI of this trial. And basically what we started looking at is those HER2-positive and triple-negative cancers, because those are the ones we see the highest PCR rates. And so basically if they were greater than age 40 and had small tumors, so T1 or T2 tumors, and then they were triple negative or HER2 positive, they had neoadjuvant therapy, and then of course we monitor during the therapy with imaging. After the therapy, if the imaging shows less than 2 centimeters of an abnormality on mammogram and ultrasound. So it doesn't have to be completely disappeared on imaging. But if it looks like it has significantly decreased to a small size, then we do vacuum-assisted core biopsies, and we try to remove that biopsy clip that was placed at the initial biopsy, and then look at those cores histologically to identify patients that have had a pathologic complete response. And so this shows, we call it the Exceptional Responders Trial. This shows the data that was recently published this year in JAMA Oncology. So basically, of 50 patients that participated, there were 31 that did not have any residual cancer on biopsy using that vacuum-assisted core biopsy. And so we were able to eliminate breast surgery. Some of them did have axillary surgery, mostly targeted axillary dissection. But those who had residual disease on biopsy did have standard therapy, and all got radiation treatment afterward. And this just shows an example of a tumor, triple-negative breast cancer, that pretty much completely disappeared with anthracycline and taxane-based therapy, and on final pathology, there was no residual disease. This shows the core biopsies that we give to the pathologist, and these are the slides that the pathologist looks at to see if there's any residual tumor. And from these slides, what you can see is on the left is a very highly cellular tumor, very aggressive triple-negative breast cancer. After chemotherapy, it's all fibrosis and scarring and no evidence of any residual cancer. And the primary endpoint is in breast recurrence, which you can see from the curve we've not seen any, and this is 5-year data. So really excellent outcomes, again, in appropriately selected patients that have had a good response to therapy. We also, in these patients, in addition to looking at at a median follow-up of 55.4 months, no recurrences, and the disease-free and overall survival is also 100%. So again, these patients who experience PCR to therapy, they seem to have the best outcomes that we can see in our patients that have even aggressive types of breast cancer. So now what about the regional lymph nodes? So as a breast surgeon, that's something that we are always trying to understand. Do we need to remove lymph nodes or not? At my center, we tend to use ultrasound of the regional nodal basins to examine for any abnormal appearing nodes. And so our radiologists look at the axilla, the infraclavicular fossa, also the internal mammary chain. And if they see abnormal lymph nodes, they can biopsy those. We typically use fine needle aspiration biopsy to confirm if there's involvement of the nodes. If we don't see any nodal involvement, then our typical approach for surgery is to do a sentinel lymph node biopsy where we can inject a blue dye or a radioisotope around the primary tumor and trace that to the sentinel lymph node. And usually there's 2 or 3 that we remove. And then we can examine those histologically with immunohistochemistry to look for smaller foci of disease in the lymph nodes that were not detected by those imaging studies that we do up front. Again, the NSABP has done trials looking at the safety of axillary lymph node dissection versus sentinel lymph node surgery. So in an axillary lymph node dissection, we're typically removing all of the lymph nodes in the armpit area, which is somewhere 25, 30, 35 lymph nodes. With a sentinel lymph node procedure, you're typically removing 2 or 3. And what we found from this trial, the NSABP B32 trial at 10-year follow-up, is that there's no difference in overall survival, disease-free survival, or local regional recurrence in patients whether they had sentinel lymph node plus axillary dissection or sentinel lymph node surgery alone. And in fact, if you look at axillary recurrence rates, which many surgeons were concerned that we would see a lot of axillary failures, the rate of axillary recurrence is very, very low in patients who have sentinel lymph node surgery only. And so again, I was involved with ACOSOG, the American College of Surgeons Oncology Oncology group, and Armando Giuliano was the PI of the Z11 trial. And so he took it one step further from the NSABP group, and he said, well, if we do a sentinel lymph node biopsy on someone who presents with early stage disease, and we see a positive node, do we actually have to remove all of the remaining lymph nodes? So in this trial, patients that had early stage breast cancer that were undergoing breast conservation and had a positive sentinel node, they were randomized to undergo a completion axillary lymph node dissection versus no further surgery. And what we found, similar to what I showed you in the NSABP B32 trial, is that axillary recurrence rates were very low and similar to patients who had completion axillary dissection. So whether they had sentinel lymph node surgery alone and then had radiation, or had axillary dissection first, the outcomes were the same. And this has really, I think, advanced our treatment of early stage breast cancer. There have been several other very important landmark trials that have been done across these decades. And as you can see, the Z11 trial here, NSABP 32, which I talked about, and then these are trials looking at sentinel lymph node biopsy alone or sentinel lymph node biopsy with radiation for women who have node-positive disease, and found survival rates being similar. In the 2010s, we started doing trials looking at patients who had node-positive disease before chemotherapy and seeing if we could reduce the amount of surgery that these individuals have. So for the women who present with clinically node-negative disease, the Amoros trial, the Cinemac trial, and the Sound trial have all been non-inferiority trials, so designed to show that less surgery is not inferior to more surgery. And Z11 and Amoros trials are very similar. So Z11 was done in the US, Amoros was done in Europe, and Z11 looked at axillary lymph node dissection versus no further surgery, whereas in Amoros, they looked at axillary lymph node dissection versus using radiation of the axilla, so replacing surgery with radiation. Regardless of the approach, it showed that 10-year survival rates and axillary recurrence rates were similar. Now, the Sound trial is also a trial from 18 European countries trying to step back even further. If we're doing ultrasound on patients at presentation of the regional lymph nodes, and these patients have early stage breast cancer, so small tumors less than 2 centimeters in size, do they even need a sentinel lymph node biopsy or not? So patients were randomized to sentinel lymph node biopsy versus no axillary surgery, just removing the primary tumor. And they found that there was no difference in axillary recurrences, no difference in distant recurrences, or deaths due to breast cancer. So again, seems to be a very safe approach to omit surgery for some individuals, some women, and this just shows the distant disease-free survival, and overall survival curves, again showing that they're all equivalent, whether they had more surgery or no axillary surgery. It does require multidisciplinary input, as all of the decision-making does now in breast cancer. And so in some cases, our radiation oncologists will say they would prefer to have a sentinel node so that they know if there is microscopic disease there, because if there is, they will treat the regional lymph nodes with radiation when they treat the breast. But if the lymph nodes are negative, they can use less radiation and do partial breast irradiation, so de-escalating some of the radiation therapy. There's still some types of disease that we have where we have more limited data, like invasive lobular carcinoma and some other subtypes. And long-term follow-up is still pending for this study. But an important approach, again, looking at these patients with clinically negative nodes at presentation, trying to decrease the amount of axillary surgery that they undergo. Well, again, neoadjuvant systemic therapy has been very helpful in reducing the amount of axillary surgery that we do. I told you before that it improves breast-conserving therapy rates, but it also reduces the incidence of positive nodes. And the assessment of response, that pathologic response, is highly correlated with survival outcomes. That's something we really want to know. We want to know if we've hit the target, if we've treated that tumor for that individual patient. And so, so for patients who have clinically negative nodes who have chemotherapy, we're typically using sentinel lymph node biopsy to assess the axilla after chemotherapy. It's the patients where we do a biopsy of an abnormal looking lymph node on ultrasound and find disease that we're not sure about the approach to the lymph nodes. And so again, going back to the Z1071 trial, we were able to look at not only the pathologic response in the breast, but also in the axillary lymph nodes, because all of these patients had biopsy-proven nodes before the therapy, and then we did axillary dissection with sentinel node surgery at the end. And again, you can see it's the HER2 positive and triple negative subtypes where we saw more elimination of the nodal disease, and less so in the patients with hormone receptor positive breast cancer. And so the Z1071 trial, the Sentina trial from Europe, the SNFNAC trial from Canada, and the Guinea trial from France all looked at these patients with node-positive disease treated with chemo, and then assessing the accuracy of sentinel lymph node surgery. So injecting the dye around the tumor and then taking out only those lymph nodes that take up the dye in the axilla or have the radioactive dye that we inject. And what you can see here in all of these trials, they had very similar rates of false negative rates. So meaning the surgeon removed the sentinel lymph nodes, there was no disease in those sentinel nodes, but then they removed the rest of the axillary lymph nodes and found cancer in those nodes. So we don't want a false negative event, because that means we're not getting the information at the time of surgery that we need. And as I showed you, that pathologic assessment of disease is very important. So one of the things that we've worked at, again, this is from some of my colleagues at MD Anderson, Abigail Caudill, and others who've coined a term, targeted axillary dissection. So in the patients who present with node-positive disease, they get a clip placed in the lymph node at the time of that initial biopsy in the largest, most abnormal appearing node. They then go on to get their chemotherapy, and then when we get ready for surgery, we place a marker similar to what we do in the breast to localize that clipped node, and then we x-ray it to make sure that we've removed that clipped node, the one we targeted, the one we really want to look at. And what we found is that the false negative rate is about 1% to 2% when you do the targeted axillary dissection versus sentinel lymph node surgery alone. And so, again, this can be done the day before surgery to identify this, and then x-raying to confirm that we've removed the target at the time of surgery. We found that this was important because when you have node-positive disease that responds to chemotherapy, remember that histologic image that I showed you where you saw a lot of scarring and fibrosis? The same thing happens in the lymph nodes. So sometimes when we're injecting the blue dye or the radioactive material, it's not making it into the lymph node, probably because of fibrosis and scarring and other things. And about 25% of the time, we won't find any of the sentinel lymph nodes that have the clip in it, even though we know that that was an important node that we biopsied before chemotherapy. And so we've been using this targeted axillary dissection, localizing that clipped node so that we have a way, a probe that we can identify that important node. Well, as we've gotten more and more patients, this is almost 1,000 patients, we recently published this, now we're down to about 10% of the time that the clipped node is not a sentinel node. So it's not blue, it's not hot with radioactive material. So we still need to localize it to identify. because the clipped node is sometimes the only positive node. Even though the sentinel, you might remove the sentinel nodes, sometimes the sentinel nodes are negative, but the clipped node still has significant disease in it. Macrometastasis, micrometastasis, significant disease that we want to identify so that patients are treated after surgery with different systemic therapy that might be more effective, because our best treatment that we gave them before didn't eradicate the disease. And so this is an important thing for us to look at. So just, the evolution of axillary surgery over my career has been amazing, because we used to do axillary lymph node dissection for staging and treatment, but now we've really switched to using these less invasive approaches. And it's important because there's less morbidity. We see less lymphedema now, especially with targeted axillary dissection. And we have millions of cancer survivors that end up having to live with lymphedema, and so trying to prevent it is a very important part of my job as a breast surgeon. So the ongoing dilemma is, do we look at the clinical disease at presentation to decide what to do, or do we look at the disease after chemotherapy? Well, I'm a big proponent to looking at the disease after chemotherapy, because that PCR is a really important thing to achieve. There's 2 other important clinical trials that I've been involved with that have been completed. So the Alliance trial is looking at patients who have a positive sentinel node or positive lymph node before chemo, get chemotherapy, still have a positive sentinel node. They're being randomized between axillary dissection or sentinel node with radiation, similar to that Amorose trial that I showed you for clinically node-negative patients. The NRG trial is an important trial because this is looking at patients, again, who start out with node-positive disease, so more advanced disease, but they get chemotherapy, and after chemotherapy, all of the disease is gone. And so we're trying to eliminate radiation in these patients. And actually, this trial was recently published. It was completed a few years. It's a safe approach that if we eradicate lymph nodes. So again, just looking at a timeline of different surgical approaches to the breast and to the axilla, it's really become a very personalized strategy for our patients. And in some cases, as I showed you, we're even able to eliminate breast surgery for certain types of breast cancer. I just want to mention my colleagues in Breast Surgical Oncology. And this, we started as a department 10 years ago, and this was one of our first photos of our group. I looked a lot younger then. This is what our group looks like now. We have 30 breast cancer surgeons in our group now. They all have, there's a very broad range of interests, research, education, quality and safety, clinical operations. Innovation is a big thing that we do. We have a whole group of surgeons who work with engineers and business people in business school who help us to innovate going forward beyond just the typical clinical trials like I showed you here. One example is I show here, which is Anna Raffinetti, who's one of our breast surgeons that works with our global oncology group. She's working with Ann Gillenwater and others to develop this low-cost, rugged system for slide-free pathology using computational microscopy. So this is a really exciting approach. Now as we have more tools, we have AI and other things, we shouldn't have to do the standard pathology assessment that we've been doing for years and years, which takes a lot of time and a lot of money. So they're looking at this as a low-cost approach, and I'm really excited about that. Another collaboration is between Nina Tamarisa and my host who invited me here to Hyderabad, where they got the Charles Balch International Scholar Award at MD Anderson this past year, and they're looking at clinical breast exam and how it can be incorporated into the standard healthcare system in India and also in the U.S. So I'm very excited to see what comes out of this work going forward. So in the title of my talk, I talked about collaboration, and what I've tried to show you here is a lot of collaboration that's occurred over the years by many different individuals. So breast cancer care is not just the breast surgeon and a few other team members like the medical oncologists, radiation oncologists. It's pathologists, imaging specialists, it's geneticists, it's plastic surgeons, it's also nurses, counselors, and patient advocates are a huge part of everything that we do. So collaborating together helps us to know more than we are capable of knowing by ourselves. So I just want to acknowledge Hannah Wingate. She's a PhD scientist who works with our group and helps us with so many of our projects, grants, presentations. And also this is my family, my husband, who's also a surgeon. Somehow or another, my daughter decided she wanted to be a surgeon as well, and so she's in surgical training. But my son was smart. He's an attorney, and he lives in Los Angeles. So I just want to say thank you again for the opportunity to be here and to share some of our work with you. It's been a real pleasure, and I'm so excited to meet more of you today and then also tomorrow. And of course, I have to say thank you so much to all of my colleagues that I work with, but also all of the patients, all of these clinical trials that I showed you. These are brave individuals who enrolled in these trials and have been able to move the field forward for the next generation. And that's what I keep telling patients that I see every day, is that I'm sorry that they have breast cancer, but we're going to work together to make it better for the next generation. So again, thank you very much for your attention and for the opportunity to be here.
Thanks very much, Kelly. I think very insightful talk. I'm sure there might be a few questions. We're happy to take. Any questions from the floor? Yes, Dr. Ramya. She's a breast surgeon based out of KIMS, Kondapur. We have another branch. KIMS, Kondapur.
I was delighted to listen to you. Such a comprehensive coverage, almost 5 to 6 decades spanning evidence-based breast oncology. I just had one question regarding the trial where we did WAB to look at whether there was PCR or not PCR in the trial that you were involved in. So I think for a lack of better surrogate to know whether there is PCR or not, we are using WAB. So the problem with the WAB, when we compare it with surgery, without surgery, we essentially are removing 12 cores of 9 gaze, which is a huge amount of breast tissue. That amount of tissue we might as well remove with an incision. So at present, can we think of any other surrogates, intracorporeal surrogates, like an MRI or a scan, to know if there is a PCR or not?
Yeah, so that's a great question. We're certainly looking at MRI, as many others are. I'm sure you've heard of the I-SPY 2 and 3 trial led by Laura Esserman at UCSF. These are trials that are trying to use advanced imaging techniques, but advanced imaging techniques such as these comprehensive MRIs and PET scans and things are not always accessible to everyone. The core biopsy does take out a lot of tissue, but it can be done in the imaging suite under ultrasound guidance or stereotactic guidance, whereas you typically, at least in my practice, to do a lumpectomy, we have to take the patient to surgery, and we usually take a lot more tissue than we need to. Even though we're trying to localize, and I showed you a nice little lumpectomy specimen, it doesn't always work that easily. And then patients, we've also, as part of the trial, the Exceptional Responders trial, we did do patient-reported outcomes. I didn't have time to show you all of that. But patients, and we also looked at how many times they had to have additional biopsies down the line because we saw things. And actually, it was much less than what we anticipated. And patients are very happy with the results. So it's not for all patients, but I think it's definitely good for selected patients. And like so many of the other things that I showed you, we have to select the right approach for the right patient.
Thank you.
Thanks.
One question. Is there any randomized trials in BRCA1 and 2 patients for prophylactic mastectomy versus follow-up? That's number one. Number two, you said conservative or a follow-up treatment for post-neoadjuvant cancers. Don't you think 55 months is too early to say the local recurrences?
Yeah.
Usually we see on the 7 to 9 years period. 7 years to 9 years, 9 years period for local recurrence.
Yes, thank you for those questions. So I think in terms of local recurrence after neoadjuvant therapy, we, for the triple negative and HER2 positive, we typically see the recurrences earlier, within 3 years. And so that's the other reason why we felt that that patient population was better one to look at than the ER positive, where we can see recurrences at 10, 12, 15 years later. So certainly, some of these patients, we're still following all of them. And when you do breast conserving surgery, whether you do surgery or radiation alone, the patient's still going to get breast imaging, and we're going to follow that. So I think so far the data looks safe. Again, it's a highly selected population. It's not by any means all of the patients that we see. In terms of the BRCA mutation carriers, I'm not aware of any randomized trials on risk-reducing mastectomy versus imaging surveillance. But there was a presentation at the San Antonio Breast Cancer Symposium this past year, and the publication recently came out where I believe it's like over 5,000 women who've had risk-reducing mastectomy or risk-reducing salpingo oophorectomy. So it's a pooled analysis from several different centers showing that patients with risk-reducing surgery have improved survival. Now, I'm not sure that, I'm trying to dissect out the data with some of my colleagues because there's a lot of overlap sometimes in the patients who have mastectomy and oophorectomy. And we've known for a long time that oophorectomy can improve survival when patients undergo risk-reducing oophorectomy. I'm not as convinced about the mastectomy versus high-risk surveillance, but I think it certainly seems to be a safe approach.
Thank you. I have two questions. One is about liquid biopsy. In a country like India, where more than 70% live in rural areas, we don't have access to mammography services. We have a shortage of radiologists, radiographers, and obviously the clinical breast examination is nationally accepted screening program, the second best alternative to screening mammography. But liquid biopsy will be a game changer is what we think. That is my first question. Second question is about endoscopic mastectomy or robotic mastectomy. Is it a hype?
Well, for the liquid biopsy piece, I certainly think that's the future. But right now, as you know, many of the trials are showing that even for locally advanced hormone receptor positive breast cancer, the liquid biopsies are not detecting that. So we're using it in some of our trials on HER2 positive and triple negative breast cancer, similar to the I-SPY trial that I mentioned earlier. And they're showing that that's very useful if you test before and after neoadjuvant therapy. Those patients who still have a positive liquid biopsy are likely to have residual disease in the breast and have worse outcomes. So that is certainly the future, but I think so many of our patients have hormone receptor positive breast cancer, and we're still not detecting that with liquid biopsy. So I think as a screening tool, it's not yet ready, unless also the cost has to be less, right? I think ultimately, if a patient, if you can send them to their local doctor and they can get a blood test, that's so much better than having all of the imaging testing that's so expensive and time consuming. And then your next question was robotic mastectomy. So that My daughter, as I mentioned, she's a surgical resident now, and she loves the robot, you know. So she tells me the other day she was on call, and she did a robo-chole, you know, which I figured out meant robotic cholecystectomy. So, you know, she was so excited. It's a great case. And you know, I think that for surgeons who have robotic training, they can certainly do the procedures very expeditiously. We have a couple surgeons at MD Anderson who are participating in clinical trials of robotic mastectomy. And when I watch them do it, they're very good. And when I'm doing a nipple-sparing mastectomy, I use that inframammary fold incision that I showed you. And I'm constantly going like this, and I don't know how much longer I can do that, you know. So I think the ergonomics is so much better. The visualization is so much better, everything. But I didn't have robotic training. So unless I go back and do robotic training now, I'm not going to be able to do it. But it's not approved. It's not FDA approved in the U.S. because of some regulatory hurdles. So right now it's clinical trials. But I went to, you know, to ESMO year before last, and one of, you know, Dr. Tosca, who's from Italy, has done thousands, and he thinks it's great, and all of his colleagues think it's great. And I don't know if you're doing it here, but, you know, I think it's going to be incorporated into the practice going forward.
Yeah, some surgeons are doing it. You'll hear about it in Kolkata. So Professor Kelly Hunt is going to be conferred the honorary fellowship of the Association of Breast Surgeons of India. She's going to be delivering our association's most prestigious oration, Professor D.D. Patel oration, later this week. So thank you very much, Kelly. And we have amidst us many luminaries across all specialities, including, as I mentioned, the senior most surgical oncologist from the Telugu states, Dr. Chandrasekhar Rao Garu is here. Dr. Manimala Garu, she's our Director of Medical Education. Our chairman, Dr. Bhaskar Rao Garu, is not here. He's traveling. He's an entrepreneur as well, and he's, you know, the hospital is expanding. He's gone to one of the peripheral centers. Dr. Manimala Garu, please come on to stage. She's our Director of Medical Education. We also have amidst us a very distinguished doctor, a doctor who heads the Indian Medical Association, not just in this state, but for the entire country, Dr. Dilip Bhanushali, please. He heads the medical fraternity across 350,000 doctors are involved. Am I right? 350,000 doctors the Indian Medical Association represents. So please come on to stage. And Dr. Chandrasekhar Rao Garu, please come and please join us in felicitating Professor Kelly Hunt.
all the organizations, like fellow organizations like API, ASI, and we at Indian Medical Association are glad that you are here in Hyderabad, giving this important orientation. Was it? Yeah. So thank you very much, Dr. Kelly, and warm greetings from my end. Thank you.
Thanks very much, everyone. Very grateful for your presence here. Thank you so much.
Some of them will get the lymphatic, some will. What are the differences? Getting that and not getting.
It's still so difficult, right? So you know what we're starting to do now, axillary reverse mapping and identifying the lymphatics and preserving them. So I think, just from looking at the axillary anatomy we have, some people, the arm lymphatics go very high.
I think I know.
And then others go right into the axilla. And we're removing those lymph nodes. So I think that's
Different. But there were different affairs. I have seen coronary syndrome, and I thought this